Step 52, a regime for frozen embryo transfer cycle. In assisted conception, we are assisting you in creation of the baby, which is a natural process. Hence, environment for implantation should be as close to natural conception as possible. In order to understand that, we need to review how natural conception takes place, how natural implantation takes place. Your pituitary gland produces two hormones, FSH and LH, which stimulates your ovaries and growth follicle, which produce two hormones, estradiol and progesterone. That sends a signal to the lining to grow endometrial lining, to prepare the endometrial lining or uterine lining for implantation. When you have a LH surge to ovulate this follicle, that LH sends a signal to the lining saying after 2 days or 36 hours, the follicle will rupture and release the egg. Most likely fertilization takes place, and after another 5 days, this embryo becomes blastocyst and implants to endometrial lining, which means after 7 days after the LH surge or 5 days after the ovulation or shift of progesterone or increase in progesterone levels, the embryo, blastocyst embryo, should come to the uterus for implantation, and in uterus should be ready for implantation, which means the implantation window should be open 7 days after the LH surge or 5 days after progesterone shift. In frozen embryo transfer cycles, we need to try and mimic that. In ovulatory cycles, we should not interfere. We should only follow your hormone levels, detect when your LH has surged, when estradiol levels gone up and down, when progesterone shifted, so that we know exact day when you are ovulating surged, or exact day when you are ovulating, and exact day endometrium will be open for implantation. If you have a PCOS, if you do not have ovulation, this process is disrupted because you don't ovulate, your estradiol levels do not go up and down, you don't produce your natural progesterone, your LH doesn't surge. This is why your endometrium doesn't get ready for implantation. If this is the case, then we need to make you ovulate by using letrozole or clomid or stimulation drugs. Essentially, whether you have a PCOS or not, by far the main determining factor what protocol should be used in your frozen embryo transfer cycle. There are 4 different types of frozen embryo transfer cycle: natural, induced, stimulated, and HRT. If you have a regular menstrual period, if you ovulate naturally, then just natural cycle is best. If you do not ovulate, if you have a PCOS, then you can use letrozole or clomid to induce the ovulation, or use very low dose of stimulation drugs like gonal-f or Puregon to help your ovaries to produce follicles. Then you can trigger with LH or HCG, or you may ovulate naturally, or you can use HRT frozen cycles. Here you use artificial estrogen, artificial progesterone. These 3 protocols are very similar to natural processes: natural frozen, induced, and stimulated frozen. This is why these 3 protocols should be used as a first line, and they give you highest chance for implantation. HRT frozen is a not natural cycle because you use natural estradiol, which shuts down your pituitary gland, shuts down your ovaries, and artificial progesterone. You don't produce your own progesterone. In HRT frozen cycles, hence you do not produce your LH for luteinization of endometrium, you do not produce your own estradiol, you do not produce your own progesterone, you have a slightly lower chance of success. This is why HRT frozen transfer cycles regime should be used as a last line of the treatment. Selecting right regime is very important because this is one of the biggest factors which determines success in frozen embryo transfer cycles.